So,
Mohammed,
yeah,
let me
like Dr. Mar
introduce
mentioned,
you.
I'm Ahmed Idris. I'm an interventional cardiologist here at Cleveland Clinic. I'm going to try to talk very briefly about TAVR and high-risk anatomy. Of course, it's a big subject, but we'll try to limit it as much as possible. No disclosures for this talk. I also will summarize the end of the case that Dr. Lubna mentioned earlier. So just real quick, I want to put this in the context of the TAVR low-risk trials. The TAVR low-risk trials, the partner 3 and Evolute here are summarized, showed that TAVR was non-inferior to surgery for the low-risk population. And this has significant implications for patients because the majority of patients operating are low risk. And what I think people need to understand is that just because TAVR was non-inferior to surgery in these trials, there were significant exclusion criteria that need to be understood and certain high-risk anatomy that needs to be put into the framework of, at least the heart team framework of taking patients TAVR versus SAVR. And the main exclusion criteria, of course, are patients in this studies had no bicuspid valve anatomy. The average age was about 73 and 74 in both trials. They also had no high-risk anatomy for TAVR that would preclude them, and they also had good transfemoral access. So I think when we discuss whether these patients are candidates for TAVR or SAVR, we need to put this in the context of these high-volume centers with very well-functioning heart teams. But there are several examples of high-risk anatomical features. Dr. Lubna mentioned one in our case, which was a short left coronary height, which you can see on the left plane here in panel A. On the bottom, panel D is actually a very small sinus of Valsalva. So you can actually cause coronary obstruction by two mechanisms, either deflection of leaflet causing coronary obstruction or sequestration of the sinus of Valsalva with a TAVR valve, and this needs to be understood. Panel B is a very calcified sinotubular junction. Panel E is a bicuspid valve with heavy calcium burden. Panel C and F show LVOT calcium that if the TAVR valve, especially balloon expandable valves, can be placed, you'll cause annular rupture, annular disruption. And that also needs to be understood that not all patients who are low risk are candidates for this procedure. You have to put in the frameworks of very adequate, very good CT imaging. And so if you talk about bicuspid aortic stenosis, why is this unfavorable for TAVR? The annulus is more elliptical, there's often asymmetric calcium distribution, bulky calcification in LVOT, and several other issues that make bicuspid aortic stenosis difficult. We all understand the Seaver classifications, but there's variability in how each one of these patients present and which ones are actually candidates for TAVR or not. But just to say, there is no randomized data for bicuspid aortic stenosis. We only have registry data for this group of patients. And of what we have, at least in this trial here, published in Journal of Medical College Cardiology, is that patients with bicuspid anatomy who undergo TAVR versus tricuspid anatomy often have more conversion to surgery, more aortic root injury, more requirements of second devices, and significant paravalvular regurgitation. Yes, their mortality might be similar between the two groups, but this are significant implications for this group. And like I said before, there's big variability in terms of bicuspid anatomy. If you look here in Seaver type 1 classification in the middle, you see the top, middle, and bottom plane have very big differences in how much calcium in the raphe, how much calcium in the actual leaflet itself. And so when we look at this variability, we try to divide it in two classifications. Either we have mild leaflet calcification or excess leaflet calcification, and then we also have either non-raphe, non-calcified raphe, or heavily calcified raphe. And even though maybe the top plane may be a candidate for TAVR and bicuspid valves, the bottom plane with heavy calcium in the leaflets, heavy raphe calcification, should not be attempted. And I think this has been demonstrated by Dr. Makar and Dr. Yoon very clearly that the all-cause mortality is much higher if you have calcified raphe and excess leaflet calcification compared to if you have neither of these two things. Not only do you have higher mortality, you also have more paravalvular regurgitation, more aortic root injury, more major vascular complications, and 30-day mortality is obviously elevated. And so I think this is very important for bicuspid anatomy. So let's go back to the case that Dr. Lubna mentioned. Again, we put a lot of thought into her case. She qualified for a 23 millimeter valve, but she was clearly at high risk for coronary obstruction. But at the counterpart of that, she was intermediate by STS, but high risk by frailty. And so our heart team met and decided that the best option with her was a measured, controlled, high-risk TAVR. And so the characteristics for her, again, that make it difficult is that she has very low-lying coronary ostia and a narrow deficient sinus of Valsalva. So we proceeded with TAVR, and initially we got hemodynamics, and here you can see the left plane that her gradient peak to peak was over 80 millimeters of mercury, and she had severe critical aortic stenosis. You can see here on the left panel here that that there's a coronary injection, you can kind of make out the aorta and the left coronary height. You see that actually between the annulus and the coronary height, it's very low, and that is always concerning for coronary obstruction. So what we often do in this scenario to try to get an idea about coronary obstruction is we use a 20 millimeter valve, we deploy 20 millimeter balloon, we inflate the balloon and then do an aortography. This deflects the left coronary crest upwards, and then we can see if there's coronary obstruction. And so you can see on the right panel, despite the 20 millimeter balloon being inflated and angiography being done, the coronary fills. Not only that, the second thing we obtained from this is there's not much paravalvular regurgitation. This is with a 20 millimeter balloon. So knowing this, we decided to use a 20 millimeter device. Again, she fits at a 23 millimeter valve for Edwards Sapien balloon expandable valve, but we decided to downsize one, knowing that we'd probably get not much paravalvular leak, and two, we were not going to obstruct the coronary. And so here, in this case here, you can see, even though we use a 20 millimeter valve, we also pre-wired the coronary, and on the right side, we put a 4 millimeter stent in the left circumflex. And what the plan would be, if we did get obstruction, is to pull this stent back into the left main, deploy it, and snorkel up if we have to avoid this obstruction. It's almost impossible to do this afterwards, so pre-planning, pre-doing this is important. And so the device is deployed here on the right side. Pigtails pulled back. This is again a 20 millimeter Sapien 3. And on the left side of the screen, we do an aortography immediately after, and you can see that the coronary actually fills. Not only that, we did this under TE guidance because she was a high-risk patient, although we do most of our patients under conscious sedation. On the right side, we see the LV function is still intact, so knowing that there's no obstruction. And there's no significant paravalvular regurgitation. You just see a valvular regurgitation from the wire itself. So knowing this is comfortable, we actually then pull back the stent and take it out. Comes out pretty easily. The wire comes out. And on the right side of the screen, we do another aortography with no wire in place, and you see no paravalvular regurgitation.
Ahmet, you have 1 minute left.
Perfect. So again, now in terms of post-hemodynamics, we have a little bit of a gradient, 10 to 15 millimeters of peak-to-peak gradient, but this is acceptable for this patient in the setting that we know we didn't cause any obstructions. The patient had really no complications. And here you can see that there's on post-procedure echocardiogram, no paravalvular regurgitation, and the gradient went from peak-to-peak 80 now down to about 19, 20. And so TAVR in low-risk patients can be done, but I think it requires a very well-functioning multidisciplinary heart team. I don't think every patient who is low risk will go to TAVR, obviously. I think this requires a really measured and decisive approach. Imaging is obviously the most important aspect between echocardiogram and CT, where we're going to select only patients who are candidates and in the randomized trials and who have favorable anatomy. And the clinical outcomes and device characteristics need to be benchmark status, and the operator and site volume and program expertise needs to ensure optimal clinical care. I think this is very important because most of the randomized trials that are high volume centers, expert centers, who are able to achieve quality outcomes. And so I'll end there, and thank you very much for giving me the time.
Thank you, Ahmet. Thank you for staying on time. Next, let me introduce Dr. Gopal Bhatnagar. He is our Chief of Cardiac Surgery. We were lucky to get him from his busy practice in Toronto. Gopal is going to talk about the role of aortic valve surgery in the TAVR era.
Thank you very much, Dr. Tuzu, and thank you very much for the organizers of the meeting for allowing me to speak. My talk will be a little less data-driven. My colleagues, Dr. Edris and Dr. Ahmed, have given you a very sophisticated talk on the workup of TAVR. Dr. Edris really covered, sort of some of the exclusion criteria that I will talk about, and it'll be far from me to dissect the details of any of the partner trials when Dr. Tuzu is the moderator of the meeting. But I would like to sort of conceptualize what surgical valve replacement will look like in the age of TAVR. We certainly know that just briefly, that in Partner 1, a randomized controlled trial, Dr. Tuzu is an author on this, that TAVR was more beneficial than standard treatment for inoperable aortic stenosis. And TAVR should be strongly considered for people who are not surgical candidates for aortic valve replacement. So in that world, the world of aortic stenosis looked like this. There was TAVR in the whole scheme of aortic stenosis. and they were SAVR, and the two really did not meet. And surgeons were very happy with that, and we all had our little fields. However, we know that now with further partner trials coming out, further data coming out, that the world of aortic stenosis is looking very much more like this, with a progressive overlap, depending on how you want to see the Venn diagrams. But the world of TAVR is certainly expanding. The world of SAVR is a little bit smaller, but we're still trying to hold our own. The recent, of course, partner trial with the transcatheter valve replacement and balloon expandable valves in low-risk patients. While Dr. Edris has certainly pointed out the details of the exclusion criteria, the subtleties of the heart team, the expertise in which the centers were done, we all know that in the modern world and in the real-world experience, that these are the only three things people will remember. The title of the paper, the fact that it was published in the New England Journal of Medicine, and the conclusion that among patients with severe aortic stenosis who are low surgical rate risk, the rate of composite death, stroke, rehospitalization at 1 year was significantly lower with TAVR. And the subtleties in the day-to-day practice in the world will be lost with unfortunate distress, possibly to patients and certainly to surgeons. And it is my fear that, in fact, in going forward, that the world of aortic stenosis will, in fact, look like this, with TAVR being a dominant player, and SAVR being pushed off in the little corner here down at the edge of the table. Now, of those of you who think that that is not the possibility, I will take you back about 500 years to the time of the armored knights. And the armored knights were the great, the big battle wagons, and felt that, well, the infantry, the little guys, they prepared the battlefield for the armored knights. That all changed in the Battle of Stenogon in 1503, where the gun was used for the first time. And these great armored knights thundered down, and in a couple of hours, the age of the armored knight was over. So my question as a surgeon really is, will SAVR survive in the age of TAVR? Now, for those, in terms of managing change, there's a very interesting book. I know this is not a new publication, and it says, Who Moved My Cheese? And essentially, if you read it, it's about a group of mice living in a cheese factory, and life is good. There's no competition. Surgeons were the only people that could do an aortic valve replacement, and we had plenty of cheese. But then suddenly the cheese started running out. And you have really three options as surgeons, and we've got to decide where we are and for individuals. We have Sniff, who looks ahead, anticipates change. If the French knights had anticipated change, they would realize they got hammered by Henry IV at Agincourt almost 80 years ago, but they really didn't see that change coming, so they were totally decimated. Scurry, we bump ahead, just go ahead, and you bump into the change. You don't really plan, you just run around, and sooner or later you'll hit change. Then there are many people who are just going to hum and haw. You stand on the sidelines, going to say, well, they're going to argue the paradigm, the subtleties of it, and really not see the change until it's too late. But nevertheless, I'm not going to be completely nihilistic and say that we do have opportunities. Of course, surgeons will say, well, we have minimally invasive SAVR. We can do this for mechanical valves because under current technology, mechanical valves are not foldable. But again, I point out that that's a matter of technology, the current state. Open surgical valve still requires cardiopulmonary bypass and cross-clamping, myocardial ischemia. There's still an incision, no matter how small, and still a time and a resource. One evolution, of course, has been the totally endoscopic aortic valve replacement. And if you take a look at the published timelines, that you'll see that for every endoscopic aortic valve replacement, we could essentially do 3 to 4 TAVRs in a hybrid room. Ultimately, we have to make sure that these are patient-centered decisions. The structural heart team assessment that has been pointed out is absolutely vital to putting the patient at the center of our decisions and getting away from surgery versus cardiology versus structural heart disease. We're looking at integrated care across the spectrum of the patient's journey, recognizing and respecting areas of expertise. I have, in my involvement with TAVR, become incredibly respectful of the ability to manipulate those little tiny wires and the skills of my colleagues. And I hope that they have come to respect that, that being able to translate open anatomy to fluoroscopic anatomy has helped us take care of patients. And in fact, I think the future of surgery of the aortic valve is a fusion of skills. Perhaps what we're looking at is a unified training pathway. And speaking with Dr. Mack on several occasions, they have established that after a cardiac surgery residency, after a cardiology interventional fellowship, that there would be access in their program to a unified pathway for structural heart disease, as this will be its own emerging specialty. And I think we definitely need to have a new mindset of cooperation as far as specialties go, and certainly what we've learned in the past with percutaneous interventions and other cardiovascular interventions is that what's most destructive is for us to maintain practice in silos, thinking in silos, and the structural heart team has beginning to break that down. Nevertheless, I said aortic valve I don't believe is entirely going to disappear. The coronary bypass's death was heralded several times over the last 20 years, and we still continue to eke out an existence.
You have 1 minute.
Aortic valve surgery in the age of TAVR, realistically, however. We have endocarditis. When you have a clinical need to actually excise a valve, excise the tissue, then open surgery still has a very positive role, endocarditis. We have aneurysmal disease of the aortic root that requires reconstruction. There's still a room for aortic valve repair, which is beyond the scope of this discussion. But there's excellent results from Dr. Levinson's last publication on the 10-year results of aortic valve repair in appropriate populations. Obviously, multi-valve operations. As has been pointed out, there were exclusion criteria in almost all of the partner trials. But I have 3 question marks behind that because really the next iteration of structural heart disease, I think, is in fact multivalvular intervention. I'll leave, Dr. Tuzo, I'll leave everybody with that food for thought and allow my esteemed colleagues to dazzle you with data.
Thank you very much, and thank you for staying on time. We're going to move right ahead to Dr. Mahmoud Traina. Mahmoud came to us from UCLA, and he is an expert in interventional cardiology and structural heart disease. His title is Special Consideration, Access Cerebral Embolism Protection. Is Mahmoud there?
Yes.
Okay, here we go. You have 8 minutes, and I'll warn you at 7-minute time.
All right, fantastic. So I was given this topic just to talk about access and cerebral protection. I have no disclosures relevant to this talk. So, I'll start off with just the importance of vascular complications is a powerful predictor of mortality, and it's been seen in the TAVR literature from the early data to the current, and having a vascular complication is a strong predictor of increased mortality. And despite the advances in the techniques and the devices over the last 10 years at a breakneck pace, vascular complications are still common. So in the SAPIEN 3 literature, major vascular complications around 6%, and in the modern Evolut-R literature, again, it's around 7%. There's still a learning curve for these complications. So it takes about 100 cases to drop the vascular complications with these. But as you can see here, in spite of very experienced operators, over 100 cases and the several hundred cases, the complications still happen at a 6% rate roughly in experienced hands. So like with anything in interventional cardiology, and more importantly in life, proper planning and proper foreseeing of potential issues and complications is really the key to avoiding these things. So access planning pre-procedure using the CT is extremely important. The patient, we need to assess the CT for looking for adequate transfemoral access in the context of other alternatives and comorbidities. Do we have the minimal common femoral artery access for dual access? Do we have a larger access that we can consider single-sided access? We have to we can evaluate the CT for access site, so sometimes trading off different risks for different locations, evaluating the tortuosity up into the iliacs and into the abdominal aorta, the location of the plaque and calcification in the arterial tree can kind of let us know where we may have issues. And identifying a proper stick location, so the location of the bifurcation, is it a high or low bifurcation? Is there any pertinent calcification in the common femoral arteries? And these can all be assessed on that CT scan. And there's just areas of high risk, so size of cover stents required in an emergency. Again, if you plan properly, you'll be ready to deal with any issues as they arise. So it can kind of really help, CT can really help us identify, in many patients with fluoroscopic correlation, where we have the calcium. So here on the right, you can see there's calcium on the tree here. We can see it's eccentric on the side. We can kind of plan around it and access either above or below, depending on the stick. I think routine ultrasound guidance is very important. You need to see where the exact entry of the micropuncture needle. You know, one of the techniques you can use is use your ultrasound on the side and along the plane of the vessel to kind of look, but routine ultrasound guidance for proper front wall sticks, I think, is essential for quality access. Use of micropuncture should be routine as well. It reduces the risk of bleeding as not every first stick is adequate. You can insert a small micropuncture sheath and do an angiography after the stick to confirm you have good location of your access before you commit with larger sheaths, and it's more comfortable for patients. Single-sided access, I think, is also a nice addition to the arsenal. This is a paper out of our main campus group at Cleveland Clinic. Dr. Tuju was on it, just published, which showed comparing unilateral versus bilateral access, suggested improved decreased risk of complications with unilateral access. But more importantly, it really allows for easier and more rapid treatment if any complications do occur, so that you're on the same side, you can get a ballooning quickly and treat the complication quickly. So at the end of the procedure, important considerations is consider contralateral bailout options in borderline cases. Be ready and be flexible to your approach. So prepare all options and really have all your peripheral interventional supplies available immediately in the cath lab to address complications quickly. So in conclusion, on access complications, the vascular complications remain common and important for prognosis. Operators must be prepared for complications, aiming for prompt recognition and treatment. Careful CT assessment underpins proper success, and you have to maintain flexibility in decision-making in context of all options. So in terms of cerebral protection, the question is it necessary? Is embolic stroke risk during TAVR still a clinically relevant problem? Are silent microembolic events important clinically? And can we improve outcomes with embolic protection devices? So the overall current generation stroke rates across all the devices is about 4% across the studies. And we know that when patients do have stroke with TAVR, mortality is dramatically increased. So if the embolic events occur, why not prevent them? And two, will preventing the embolic events improve outcomes? So there's a couple of devices on the market. This is one of them, Sentinel. It's delivered through a transradial sheath where you put them into the bilateral carotids. There's a Trigar, which is a transfemoral delivery system that you can, again, blocks across all carotids. So there's different devices that are out there. And so what's the case for embolic protection? So it's mostly, a lot of it comes from the thoughts of carotid stent experience. It's been well proven that embolic protection in the carotid stenting era dramatically decreases risk of stroke and decreases risk of volume of MRI lesions. And these MRI abnormalities, even silent infarcts, are not benign. So we have data that shows that patients with silent infarcts have up to 5 times higher stroke risk as those without. So there's something to these benign, these asymptomatic lesions. And studies have routinely demonstrated that embolic protection devices reduce MRI abnormalities after TAVR. So this is kind of a meta-analysis of the 5 randomized trials. So I'll point out that each of these trials independently did not decrease risk of stroke. However, as a meta-analysis, there was a strong favoring of embolic protection to decrease risk of stroke. So these trials kind of show that they decrease MRI abnormalities. They show that as a group, they probably decrease risk of stroke. But the potential for clinical benefit beyond that is in terms of cognitive improvement as well. So if we can prevent embolic events, why not do so? This is kind of from the Sentinel study on the debris capture and showing that you get all kinds of stuff in these. So it's not just clot and thrombus and clot, but you get arterial wall, valve tissue calcification, foreign material from the catheters and the balloons, all of that can potentially embolize. So what's the case against this? So why not routine? Well, number one, stroke rates are decreasing. So we saw modern area strokes from the SAPIEN data shows that stroke rates, disabling strokes, are less than 1%. and all strokes are in the 2% or less range. And the stroke rates may not be same across all the devices, so that's kind of important to kind of evaluate. Stroke rates are decreasing, but it's not really, it's independent of experience and operator volume. So even in very experienced hands, the stroke rates kind of persist and fly as compared to other complications with decrease with increased experience. The current devices don't reliably protect all the cerebral vessels. They increase the complexity and the risk of the procedure, so there's manipulation of the cerebral vessels that happens, you need additional vascular access, and no single study has proven any definite clinical benefit. And MRI changes, though are important, are not necessarily an adequate surrogate endpoint for real clinical outcomes. But probably the biggest case against embolic protection is cost, and that's, I think, a major limitation in settings from the developing world and the first world. Is costs of these devices is also a major issue. Thank you.